Great. And I went ahead and started the recording too, so we are good.
Fantastic. Looks like people are still calling in, so we will wait another minute or two and then get started because I think we have a relatively full agenda. And I really apologize. I have this cough that will not go away. So you all are going to be forced to listen to me for the next 30 minutes or so, and I'm sorry for that. Looks like a few people are still logging in. I see a couple that are waiting for names, so we will get started in about a minute.
Hi, Mike. This is Steve.
Hey, Steve. I see you. All right, well, my clock says 8:02, and I see that a few more people are still logging in, but let's get started. Let me know if you're able to see my slides okay. The first slide should say Combined Communications Strategy. Are you all tracking with me?
Yes.
Perfect. So this is the first of our PI coordinator calls, which we intend to have on a monthly basis. And part of this is us sort of rethinking what the most effective and efficient communications strategy may be. I think you all got the messages that we've decided to eliminate the weekly huddles and the weekly emails with recruitment data. I've heard from some of you that it's just sort of too many calls and too much of an email volume and hard to keep up. You know, just for historical perspective, we had started the weekly huddles, you know, about a year or so ago when the first couple of centers were just getting activated. And we really wanted to use those as sort of a brainstorming session to kickstart recruitment. But at this point, since we are well underway, I am getting the sense from many of you that the huddles may be a little bit repetitive from week to week and may not be the most efficient use of your all's time. And I think a lot of you have spoken with your feet in that many of the huddles have not been well attended. And so in lieu of our weekly huddles, we are going to try the following. You all should have received yesterday afternoon the first of an expanded newsletter. Our newsletters have a little bit more recruitment data in them rather than the monthly emails with the PowerPoint slides. The newsletters have reminders and other updates. We'll be sending these out every other week, and please do read them. They're a short read and just have a lot of sort of to-dos and tips for coordinators, tips for providers, and other announcements. And each newsletter has a link to more detailed recruitment data for those of you who are data buffs, and that link will point you to the right location on the SharePoint site. We'll be hosting monthly PI coordinator calls. This is the first one of those, and it is really important for as many of you, both from the PI perspective and the coordinator perspective, to attend as possible. We will be recording these calls and posting them to SharePoint, and emailing slides later on as well. So if you're in clinic or have another commitment, we get it. Please try to at least review the slides, if not listen to the recording. We will continue to have in-person meetings at our community conferences as we have in the past. We are thinking about the best way to organize a second monthly call for coordinators only, to really focus on some of the operational aspects of recruitment and follow-up and data entry, and how to use efficiently and effectively the tools that the data management team has developed. And we're still considering other forums to facilitate the sharing of best practices amongst coordinators and PIs. So if any of you have ideas in that regards, please reach out to me directly even, and we'll continue to build upon that. So big picture is we've heard from many of you that the weekly emails and weekly phone calls are a bit much, and we're trying to present information to you all in more efficient ways as shown here. I'd like to take a moment to give a special thanks to Michelle Robinson, who many of you know was instrumental in getting this project launched. And her last full day on the study was November 3rd, though she still is working part-time for us. She is starting an independent consulting business for sort of trial startup and operations. So I think her talents and experience will be well utilized by others. And really, her efforts were instrumental in building the trial infrastructure that we have today, including getting the protocol together and entered into clinicaltrials.gov, all of the site training, helping to organize and kickstart the site and data coordinating center at Cincinnati Children's, developing our process for SAE reporting at UNC, creating our data safety and monitoring board, organizing the central pharmacy, coordinating the placebo manufacture for our 3 treatments at Temple, organizing the biobank, which is housed at UNC, coordinating with the patient-reported outcome core at the Children's Hospital of Philadelphia, and forging partnerships with our 2 reference labs, Grifols and Mayo, that will be ultimately measuring anti-TNF levels and antibodies on our banked specimens. As many of you know, Michelle has been a really great resource for sites as well, and fielding any questions or providing advice along the way. So we will definitely miss her, but don't worry, because we remain in really good hands. This next slide is sort of a who's who with Combine. I know that there are multiple points of contact for multiple different issues or aspects of the project. I'm not going to go through this slide in detail because it will be posted to SharePoint and emailed out, but I just want you to have it as a reference so you know who to contact with what. And again, at the bottom, I am always willing to be contacted at any time for anything, and promise to any of you a quick turnaround, unless I happen to be on a desert island on vacation, which happens too infrequently. All right, moving on to site activation and recruitment. Here is where we're at as of the end of the week last week. We have 41 sites selected. We're in the process of interviewing a few more. 35 sites are now activated. 2 are super close. 3 are newly selected and in the early stages of IRB and contracting, and 1 we just notified of their acceptance last week. We now have 92 patients randomized, so we're making good progress towards our goal of 425. 24 of our 35 sites have recruited at least 1 patient, and our leaders are Cincinnati and Children's Hospital of the King's Daughter in Norfolk, who have each recruited 10 patients. So special shout out to those sites. Here is our sort of cumulative recruitment graph that you all are used to looking like. The green line is where we had hoped to be, and the orange and blue lines are where we're at. The orange is the number of patients consented, and the blue is the number of patients randomized. And just like when I presented this 3 months ago, we are about 6 months behind schedule. So making progress, not all that bad for a 5-year project, and we're no longer losing ground. We're sort of, our blue line is roughly paralleling the green line at this point. And again, here is our recruitment by site. This slide is about 1 week out of date, but again, it highlights Norfolk and Cincinnati, and Riley, Riley Nationwide and Nemours Wilmington are giving them a run for their money. So great work to all of you, and particularly the sites that have just sort of broken the ice and gotten going. I think we can all tell you that the first patient is generally the hardest. All right, I'm going to turn it over to our sort of mini focused group that is thinking and brainstorming about ways to catalyze recruitment for each of the sites. And that is Shazad, who you all know, Julie Massey, who is one of our quality improvement coordinators, and Cole Jackson, who is a longtime friend of Improved Care Now's and former Improved Care Now research specialist who's back with Combine at least till the end of the year. Shazad, do you want to present, or Julie?
Julie, if you could go ahead, I think.
All right, I will go ahead and get started. Good morning, everyone. So first I wanted to bring up our key driver diagram, which just shows, again, our SMART aim on the side, which we were looking for 425 patients to be randomized, 100% of the centers submitting data weekly, and more than 90% of patients identified would be approached for consent. Our improvement work has really centered around 3 of our key drivers, which we will touch on, and I know this is really tiny print, so we'll go ahead and move on to the next slide.
And can everyone mute if you're not talking, please? There's an echo.
Mike, if you want to go ahead, or Michelle, flip my slide. Thank you. So just to kind of highlight where we're at, we mentioned submitting data weekly as one of our key goals. And this is where obviously a lot of the data comes from that Mike just shared. And so we've set our goal at 95% of the centers submit weekly data. And so more recently, we've noticed a dip in our data. And so we've started to monitor that a little bit more intensively by doing 2 key actions. We're really trying to identify sites that have not submitted data 2 weeks in a row to offer assistance, and then also identifying best practices. There are a few sites that were newly activated, and we're trying to identify and kind of standardize, once they're activated, how soon we expect data submission. And so we've started to find a few sites that were able to ramp up within 2 or 3 weeks from being activated. And so we're going to be reaching out to those sites to identify a best practice and really kind of set that standard to help other sites as they join Combine. The 2 drivers that this actual measure is impacting are really helping us find network processes and structures to facilitate the collaboration, information, and knowledge sharing among the participating sites, and then also developing clinic workflows and processes that support the engagement, recruitment, and retention. So you can see we still have a little bit of work to do. We're right around 75% right now, and we'd really like to see that grow each week. And so we'll continue to monitor this. Next slide, please. Our next goal has really been to look at sites that are activated 3 months or more and begin to identify if they're developing progress in approaching or consenting eligible patients. So we've developed some weekly monitoring metrics that really look at the data that is pulled from the weekly submissions to see how many patients have been approached, again, shooting for that 90% or more approach rate, And then out of those, how many were actually consented? And so our 2 activities around this have focused on improvement by monitoring, again, the current dashboard to see how progress looks. We know that week by week is too much to look at, so we're looking at kind of a 4 to 6 week look back to see how much sites have, how much the data has changed, and not only identifying the eligible patients, but approaching and consenting. And then again, one of our outreach strategies to develop improvement in this area is to do some site pairing calls, which we're just starting right now. And that's identifying a way that one of the higher performing sites can work with sites that are struggling in any one of these areas or that have interest in improving these processes by sharing information and developing kind of some standardized approaches that, again, are best practices throughout the study. Same 2 key drivers are impacted on this measure as well. Next slide. And so our last key driver that we've really been focusing on is real-time learning from transparent data to support and improve engagement, recruitment, and retention. And so we've developed some metrics that we review on a weekly basis just to see how our progress is going. And again, identify some standards that we would expect to see so we know when to react and when not to react. So as we're doing this and we're developing our standard operating procedures, we're looking at, again, as I mentioned, the % of centers submitting data on a weekly basis. But then we're also looking at change in patients that are pre-screened, eligible, approached, consented, and randomized. And so we started to plot, again, some charts that you can see in very tiny font up in the corner. But you can see the steady progression on each one of these factors and how many of the patients continue on to the next phase. And so again, just trying to identify some triggers that would show when we have areas that we need to focus on and monitoring that weekly change so we can set some standards and some targets week by week. We've also began to color code the site performance on the dashboard, and so we're monitoring that as well and including you know, some information on randomization when we look every week. And the next slide. And so what you can expect from us moving forward is increased communication via email and phone. We're starting out with Shahzad emailing PIs and coordinators regarding the weekly data submission, activity since activation, and then also beginning to identify improvement opportunities, whether they be best practices or, again, just helping identify where processes aren't going the direction we'd like them to go. And we're starting to also include updates in our newsletter. So you'll start to see more information in the from the weekly combined update that was previously emailed. We will include that in the newsletter moving forward, as well as successes and acknowledgments and where our progress goes on improvement. And the last slide. So as Mike mentioned, this is the team. If you have any questions, feel free to reach out to any one of us. And I will turn it back over to you.
Thanks so much, Julie. And I think, Dan, you are up next to talk about data reports and exceptions.
Excellent. So good morning, everyone. I'm Dan Jeffers. I think I've been around ImproveCare now for a while, but just making a comeback to help out with some of the combined work on the informatics side. So just quickly this morning, some of the things that are coming up over the rest of the calendar year on our side are some updates to exceptions. Actually, the first list of items were things that we put out in the world yesterday, so you may start to notice some updates. We're just noticing over the first couple of rounds of patients that there were some issues with the exceptions as they existed. So things like the CRP upper limit of normal was causing some grief and may have not have been programmed correctly. So we were able to fix that and put that out in the world yesterday. There were some issues with some AE and SAE exceptions missing an equal sign. So there were some oddities going on there, and we were able to put that in the world yesterday. And then just a couple of exceptions that turns out we had created that didn't really provide much value and were causing more grief than they were worth around enteral therapy. And on the visit review form, the hospitalization date having to be between combined visits, which just didn't make any sense. So we turned that off as well. Over the next month and a half or so, we'll be rolling out a couple of additional reports detailing things like the list of medications that each patient is on, the list of dose changes that have happened at your center, any out of range labs that you may have and may need to check up on or follow up on in terms of retesting or adverse events, and then just a list of hospitalizations that come from the registry, which I think also will be useful in terms of just double checking adverse event reporting. Next slide. So we can skip this one as well. So Mike asked me to go through a couple of things that we may have out there already that people might not be aware of at this point. So one of the newer reports is just called the Provider Review Needed Report. You can find this on the Reports tab within the combined portion of the registry. And this is just going to be a list of all of the events or visits within Combine for all of your patients where a provider review is expected, so that sign-off page at the end, but it hasn't been completed yet. So things like the regular visits. So on the example, you can see week 4 and 14 showing up quite a bit. Adverse events and dose changes are also going to show up here where there's a provider review that's required, but it hasn't been completed yet. And so in a lot of cases, especially on the visits and the dose changes, that provider review is going to trigger a change to the pharmacy. So it's going to be important to follow up and to make sure we're getting those done, to make sure that we're getting the right dose or the right number of pills or the right refills off to the patients as that comes up. So this should be a pretty useful resource in addition to the emails that are already going out, just in terms of making sure that we're getting everything we need to do over to the pharmacy in a timely fashion. Next slide. So the other one related to the pharmacy is the pharmacy shipment report, and this is an old one, but I thought it worth mentioning again. So this is a good place to check to see if you expect a patient to have been randomized, and it's not obvious to you in the trial system what's going on. You can go over to this report again on the Reports tab of the combined study portion of the registry, and once your patient has been randomized, they'll show up here. Regardless of whether or not the drug has been shipped or not. So if you just randomized a patient, if we look at the first row, if this patient had been randomized and no shipment had been done, all the shipping date and number of pills and shipping method and tracking number just would be empty. So that's another tool you can use to confirm that randomization happened as expected. I know we get a lot of questions on that, just to confirm that it did, and this is one place to go. Another kind of cool feature of this report is the tracking number. So if you are wondering where a shipment may be, you can take that tracking number, copy it into Google and search, and you'll be able to pull up tracking information on any of the shipments that go out without having to log into any sort of FedEx site or whatever. It'll just be available there through a link. So that's there as well, should it become necessary. On to the next slide, please. The last thing I want to talk about is just a couple of tips on exceptions. We know that there are a lot of them, and that's something that we're going to be looking at over the next couple of weeks now that we've got those bugs worked out, and we feel like things are in a cleaner state, where the plan is to look at the exceptions sort of by frequency and look at those that are occurring most often and see if there are things we can do to make them less burdensome, or if there are exceptions that are firing that don't provide much value, if they can just be turned off and sort of reduce the burden there. So I just a couple of things to focus on in terms of the highest value, the sort of the return on investment for effort here would be just to look at things like any exceptions comparing the registry versus combined. So if it says there was a visit in combined but no visit in the registry, or hospitalizations in the registry but not adverse events in combined, or things of that nature, those are going to really get us the most complete set of data that we can for the DSMB and ultimately for the final analysis. So those would be the places to focus limited resources. And also on the core labs, I think what we're finding is that especially the registry labs, that we're finding they're not completed as often as we may have expected. So exceptions around those sorts of things are going to be the place to really put most effort if you're limited in the amount of time that you can spend. And then just at the bottom of the page, the most common exceptions that I'm seeing based on a count that I pulled yesterday were for hemoglobin out of range. That's something that we're going to go ahead and change. I think ultimately what we'll do is take the exception off and then put just a soft check on the form rather than make you respond to an exception, because I think what we're finding is that the range may be too tight, and a lot of these kids really do have lower values than what was initially programmed. So we'll remove that and hopefully make it a little less burdensome there. The CRP upper limit of normal missing at screening is still still fairly common in terms of overall numbers, which common is not like every patient has them. I think we're seeing about 10 or 15 of these still showing up in the reports. So this was just put here as a reminder that if you have issues at screening after the patient has been randomized and the visit is locked, you'll just complete that data change form and send it over to us, and we'll take everything from there. And then the last one is just missing ICN-2 items at the visit. Just exam items and lab values, again, missing from ICN registry visits. Next slide. And the last thing is just a plea for where do you need help? What can we do to make things easier for you? So there are areas of the registry, the reports that are confusing, or there are more exceptions that are causing excess stress, or anything we can do to make your lives easy. Please reach out to us at the help desk or reach out to me individually, and we'll do what we can to assess those questions and make things as simple as we can. And I think that's all I have, so I'll throw it back to you, Mike.
Thanks, Dan. And I will just take this opportunity to briefly introduce Janine Dahlquist to those of you who have not had a chance to virtually meet or interact with Janine yet. She is our study monitor and is going to tell you a little bit about sort of the scope of work that she's looking into to make sure that we are doing everything we need to conduct a high-quality study. Janine? Good
morning. Thank you, Mike. I appreciate that. And I am happy to share. I will try to give a 30,000-foot view of what monitoring looks like for a pragmatic trial that is following standard of care for the most part. However, we are working with an IP or investigational product, and so we're balancing that in our monitoring. I can tell you the monitoring for this study is entirely remote, so I will not be showing up at your site. It is also what we call risk-based, and if you're familiar with that term, you know that it's very focused on critical data, safety of the participant. So as the monitor, I'll be looking for, of course, protocol compliance and good clinical practice, clear documentation of oversight of the participant by the study staff, and of course that's always especially adverse events and oversight of the PI and all of that documentation that's required on any research study, because these are human research subjects. We do have that level of oversight required. So those are the general, you're all been monitored before, and that's all an approach that you're used to. The ways that this monitoring of this particular study might be a little bit different is the remote aspect. I can tell you that I try to send an email notification of your remote monitoring visit 30 days in advance. And I do include on that email a list of what I'm looking for at that particular visit. It will be a little different at each visit, and visits will be, for the most part, annual. Of course, if you're used to risk-based monitoring, you know that more findings mean more visits more often, and more compliance means you see the monitor less, and that's just the way the risk-based works. New staff at a site will bring closer monitoring, and I'm always there for questions. I'm always there to help, but as far as the actual monitoring visit, those will mostly, for the most part, be an annual visit. So as I said, we're looking at protocol compliance, good clinical practice, clear documentation, all critical components of good research and getting good data in the end. And all monitors have a different approach for getting this done. But I will be working with you throughout the review. I do ask in my notification letter that you set aside time the week that I am doing the remote monitoring, and that's only because I want to give you the opportunity to interact, to answer to some of those findings. Some of them can be resolved right away. Some of them are very simple oversights that you can make go away. Or that a simple explanation to the monitor resolves them, and I want to give you the opportunity to do that. And it's also really the only chance I get to interact with you, to talk about the study, how I can help things to go maybe a little smoother, where the challenges are, all those types of things. So again, I'm available to you at any time, but during that week I'm really focused on your site. And so anything that's been a challenge you'll want to bring to my attention that we can talk through process and improvement and help you get on a good track. So that's what we call the monitoring piece. We also have an additional piece in this study called the quality review. And it's also going to mean that you're hearing from me, but maybe from a different approach. We do have a programmed review of the data. And what that looks like, if that doesn't seem clear to you, this is simply programming the if-then. So if your response was yes here, we should see a no here and a yes down here. And whenever anything pops out on the data is not quite right, it is drawn to my attention, and then I'm going to be reaching out to you. So you will see these emails come through without warning. You won't get a letter that they're coming. They'll just be a simple email giving you a list of what the findings outlined, and please would you address these as soon as possible. I will tell you that the expectation in monitoring is normally a response from a site within 2 weeks. I am aware that you're very busy and this is not the only thing you're doing in your life. So if the 2 weeks is a challenge, simply send me an email, let me know. I'll work with you. It's not a problem. The more, of course, findings you have, the longer it's going to take. And again, I work with the sites on this and help you to get them resolved. So it's not to worry. There'll be a lot of reach out in the beginning. We're just getting this started. In the next couple of weeks, you may hear from me a lot. Once these are resolved, the expectation is that these little reach outs on the quality review will become less and less. So we're looking at data mostly monthly. There are a few checks that are weekly, and I'll reach out to you via email on things that you need to, items that you need to resolve. So, and that was the next slide. I'm sorry, I forgot to tell you to go forward, and I'm working from my phone. So that was the quality review slide, and now we're down to a reminder about documentation, if I could just really quick. I want to give just a very, very brief reminder the importance of documentation. Of course, the saying is in research, if it's not documented, it didn't happen, no matter what it is. So I'm going to try to share each time that we talk a little bit about what the expectation is, and a very important one is the difference between what you're documenting as a deviation and a note to file. And I know at the onset of the study I was not as involved, and we had a note to file that was all-inclusive. It had a kappa within it, and it had a deviation within it. And we did pull that off of SharePoint, and I provided for you a separate deviation log and a note to file log, and you can take a look at those. And if you need help with the difference, I've posted some definition there, so you can take a look at that. But we're trying to get in our regulatory review that is a part of our monitoring, we are trying to get all sites up to speed on the regulatory side of things, and that means that all deviations are documented in a unified sort of manner so that everyone looks the same and everyone's documented on a log. So we've got a lot of work ahead of us. It's all good work on a great study, very important questions we're asking, so I'm happy to be on board, and again, I'm available at any time. My email goes out, and so does my phone number. With every email I send, so don't be afraid to reach out, and I'll get back with you as soon as I can.
Thank you so much, Janine. I realize that we are at the end of our 30 minutes. We'll continue for another 5 or 10 minutes, largely to complete the webinar and for the sake of recording. If you're able to stay on, that's great. If you need to leave, we understand. And you can catch the tail end of the slides and recordings after the fact. So Michelle, JP, you want to give us a high-level overview of what is in our manual of operations and procedures and how to use it and how to find it?
Sure. Good morning, everyone. So we just wanted to touch on the MOP a little bit, as we often do on the calls, and just remind you that we hope that you are using it as your source, and it's to help you with the how-to aspects of the study. It does not replace the protocol. The protocol will still take precedence if something differs, and if you notice something differing, please let me know. And it's a living document that is updated regularly and will be throughout the course of the study as you know, things change. So we just want to make sure you know where to find it. It is on SharePoint in the study resources section. Then you just scroll down until you find manuals and procedures, and it says Combined MOP version 3.4. And this is what that looks like. So if you're in the study resources section, it looks like this, and you can see where it is there. Next slide. So for using the MOP, please refer to the protocol and the MOP when you have a study procedures question. If you cannot find the answer yourself, please email me or Combine help with your question. And for any items that you can't find in the MOP, we want to know, and we'll add them in future updates. And we'll continue to post updates in our newsletter that Mike talked about earlier. And the updates are, every time we update the MOP, we notate that at the beginning of the document, so you can see what's been added every other week. This is the front page of the MOP, and you can see what version we're on and the last time it was updated. This is the table of contents. It just keeps getting longer and longer. It's a big study with lots of parts. And that is, in general, what it looks like.
All right, thanks, Michelle. And in closing, I just have a few other updates that I wanted to share. Again, a reminder that after randomization, there are a number of key activities that we do over the 24 months of follow-up. Most importantly, assess clinical status of each participant regularly and assess whether he or she has met any of our study endpoints that would require us to discontinue treatment. That patient remains in follow-up, but off treatment once he or she meets any endpoint that would indicate either failure to achieve remission or subsequent loss of remission. And of course, we also use visits as an opportunity to assess for adverse events and serious adverse events. Patient-reported outcomes are collected and sent to CHOP at weeks 14, 26, 52, and 104. Biosamples are collected at either week 14 or, if forgotten, 26, and at either week 91 or, if forgotten, 104. It's important at every visit to collect, destroy, and document any unused study medications. And then, of course, data entry, which is not only the Combine visit form, but the accompanying registry form, and then any updates that are needed to the concomitant medication form, the colonoscopy forms, the lab forms, et cetera. So very important to keep all of that data up to date. A word about our follow-up visit schedule, which really was designed based on routine care of pediatric Crohn's disease patients initiating anti-TNF. After the first 3 months, the windows become relatively broad to accommodate a wide variety of clinical practice styles. We strongly encourage you to schedule patients for visits during the recommended windows as it is clinically appropriate. We understand that some visits may be skipped based on clinical, logistical, or other factors. That's okay, but missed visits still become protocol deviations. Again, no major biggie, but needs to be documented as such. We also understand that sometimes patients are seen more frequently than the visit schedule, and all of these should be entered as additional visits in the Combine database, and of course, captured in the Improved Care Now registry as well. We've had a lot of questions around the next couple bullets, so pay attention here. For patients who are not seen during one of the visit windows, but seen just outside of that window, like plus or minus 14 days, it's okay, and we encourage sites to record that as a study visit. So if you're not seen at the week 26 window, but you're seen just before or just after, document that as a week 26 visit, complete the week 26 visit case report forms, and whatever else might be due at that visit, whether it be PRO collection or biosample collection. And even if the visit is a bit before or a bit after the window, as long as you document it as such, we can pay you for it. If more than one clinic visit falls within the window, you only need to enter the first visit as that visit, and the other visits get entered as additional visits. We generally encourage sites to use the first visit that falls within a window as that sort of window-based visit, because it's really never certain when the next time the patient will actually come to clinic. So you might be expecting 2 visits during that, say, week 26 window. Use the first one if you can as the week 26 visit. Check it off, you're done. And if there's a second visit that happens during that window of time, that can become an additional visit. That way we have at least 1 visit per window, and we can do the study procedures that need to be done during that visit and pay you for it. A word about the provider review as well. As you all know, the primary purpose is for the provider to sort of review everything, particularly regarding the study endpoints, decision to either continue treatment for patients who have not yet met an outcome or discontinue treatment for patients who have met an outcome. It was brought to our attention that the provider review makes absolutely no sense for patients who have already met one of our endpoints, have stopped treatment, and are now in that status of in follow-up but off medication. It really makes no sense. I'm totally sorry about that, and we are working on a fix for it. So, the provider review is super important for patients who have not yet met a study outcome. For patients who have met an outcome and they're off drugs, it becomes kind of irrelevant. I apologize, and we will fix that for you. A word about withdrawal of consent. We've noticed that some sites have indicated that a couple of patients have withdrawn consent. And this is a little bit of a technical aspect that we're going to be creating some guidance on and talking about in a future call. So this is just a little bit of a preview. Withdrawal of consent should only happen under super rare circumstances. We expect that a lot of patients may stop treatment but continue in follow-up after meeting a study endpoint. That does not constitute withdrawal of consent. And similarly, patients may say, once they're in the study, they've gone 3 months, like, you know what, this isn't for me anymore. We get it, that's going to happen. They can choose to stop the study at any point. That also is not withdrawing consent. It's just stopping the study, but they've consented for the study to begin with, and all of their data up to the point that they no longer want to participate is analyzed as a sort of time to event analysis. So really the withdrawals of consent, should be if the consent wasn't obtained properly for some reason, or, literally like the patient went home that night and changed their mind before anything really happened as part of the study. We're working, like I said, to sort of address this and come up with a good sort of process and guidance for you all to follow. But in the meantime, if there's any questions about whether a patient has actually withdrawn consent or not, get in touch with Michelle, JP, and she and I and our regulatory folks will sort of help you sort that out on a case-by-case basis. And finally, in terms of phone calls, just a quick reminder to complete phone calls after shipments and enter that data into our data capture system. All right. Thank you for all of your help and attention to detail and enthusiasm over Combine. Thank you for staying with us 10 minutes over time this morning, and we really appreciate it. We will group again next month, but until then, if there's any questions or anything that comes up, you know where to find us. Have a good day and good week, everyone.